So I want to kick off the morning's presentation by talking about service design. I want to talk about how the different elements of the services design shape staff's ability to collaborate with one another and share knowledge effectively and integrate mental health and AOD practice. And in doing that, I'm going to introduce a framework, which is a kind of thinking tool, which I think helps us to design better services. So as I mentioned, I've been doing some research for the last couple of years on our Neami mental health and wellbeing locals. And so this talk's based on that work. So our local services are integrated mental health and AOD services for adults aged 26 and above in the community. And like all the local services, they're intended to be easily accessible. So we have a walk-in element and we have a referral element. And then they target that missing middle between frontline GP care and more acute forms of care. And we actually have, we now have 3 local services. So we've got one in Whittlesea, which is in the northern suburbs. We've just opened one in Tharrabin, and we have a service in the Trobe out in Gippsland. And so what this talk is going to focus mainly on our Whittlesea service, and you'll hear a little bit about our Trobe service from some other presenters in a bit. But everyone in this room will be aware that those local services are new and they're quite innovative in that they bring together that mental health and that AOD support under one roof, whereas in the past, a lot of parts of the sector have been siloed of those sectors. So because of that kind of innovative nature of the service, we've been doing this research project in the last couple of years to understand how we can better design integrated services. And as part of that, I've been doing research with all of our local staff. So in the middle of last year, in July, I sent a survey to all our local staff, and that survey was designed to look at how was integration going in our services. And then right after that survey happened, the service made a number of service design changes. So it restructured to try to improve integration in response to some challenges we were having. And then I went back a few months later, so in February this year, to do the survey with our staff again and look at what changed as a result of that restructuring. And I'll tell you about that research in a minute. But before I do that, I want to introduce this framework to you, which is the 3 elements of service design. So these are the 3 elements that I think we need to pay attention to when we're thinking about service design. And what I'll do is I'll introduce each element briefly, and then I'll give you a more detailed example from our Whittlesea service. So the first element of service design is what I call the formal workflow. So that's the step-by-step process by which work gets done in a service. The second element is the formal organization. So that's how the service arranges its people and its jobs in order to execute the workflow. So that's the things like the setup of our teams, the design of our roles, the setup of hierarchies and leadership structures. And then the third element is what I'm calling the informal organization. So that's all of staff's actions and behaviors as they self-organize and collaborate with one another to actually get the job done. So if you think about it, that's everything else within a service. And usually that's not very visible, right? It's hard to know what's going on there, but I'll show you some methods we used in a minute to kind of make sense of that informal organization. But by looking at these 3 elements and how they interact with one another, we can understand service effectiveness and think differently about how we design services. I'll give you an example of that in a minute. So in a bit more detail, this is our formal workflow, and this is a visualization of the workflow at our Whittlesea service at the time of the first survey in the middle of last year. So essentially that's all the high-level tasks and activities that happen from the point in which the consumer enters the service all the way through to exit. So at that time, we had this initial engagement period where a consumer was referred or they walk in. Then we had an intake assessment. Based on that, the consumer was allocated to a 2-person care team of a peer and a clinician. And then that care team did a series of structured assessments and developed an individualized care plan, delivered up to 12 months of care and support, and finally the person was exited from the service. So obviously an actual workflow in a service is a lot more complex than this. There's a lot of tasks, activities, decision points underneath here. But the point about this is how we set up this workflow is a really important decision in the design of our services. The second element is the formal organizational structure. So that's how we actually arrange our people and our jobs to actually execute that workflow. And at the time of the first survey, this was a big part of our Whittlesea formal structure. So we had this rotating roster structure, and we had 3 different kinds of duties that staff could be assigned to. We had intake duty, doing that intake part of the workflow. We had floor duty, which was managing our walk-in centre. And then we had care and support duty, which was doing all the other care and support. And the key part about this was that a member of staff at the time could have been allocated to any one of these duties on a given day, and they might be doing a different duty from day to day, and that rotated round on an 8-week basis. And this structure we had created a lot of challenges for collaboration and integration, and I'll tell you a bit about those in a minute. And then finally, we've got our informal organization. So a really important part of the informal organization is the collaborative relationships that staff use to get their jobs done. So this here is what we call a social network map. And this is, we collected this data by asking our staff, who do you go to for work-related help or advice? And so all the colored dots here are all the staff in our local services. This big cluster here is our Whittlesea service. The little one is the Latrobe service. And there's an arrow from, the people are colored by their job role here. And there's an arrow from one person to another if that member of staff told us, I go to this person for work-related help or advice. And so if you think about what it means if you give someone advice at work, you're actually providing them with some of your knowledge, right? So we can think of this as a map of knowledge sharing in our services. And this can be really useful for understanding integration, because by looking systematically at which roles are sharing knowledge with which other roles and which roles aren't, we can start to understand how integrated our services actually are. How did we collect that data? Well, in the staff survey, I gave everyone a list of all their colleagues, and I asked them just to tick off the names of who do you go to for help or advice, and then you aggregate everyone's responses and we can map that network. So coming back to our framework here, the key idea is that service effectiveness comes from the interaction between these three different elements of service structure. And by considering the interaction, it helps us to think in a kind of a sort of complex systems way about how to design our services. So I'm going to give you an example from our Whittlesea service of integration between mental health and AOD staff to kind of illustrate the usefulness of this framework as like a thinking tool for helping us do service design. Coming back to our network, this is just the Whittlesea network here at time 1, so we don't see our Latrobe service anymore. And this time I've coloured our staff by their mental health or their AOD role. So you can see the AOD clinicians are the red squares here. The mental health clinicians are the blue squares. The blue circles are our peer support workers with lived experience of mental health. And then the red circles are our peer support workers with lived experience of AOD challenges as well as mental health. And as I said, one thing we can look at is which roles are sharing advice and knowledge with which other roles. So one thing that stood out at this time was that our AOD clinicians up in the corner here, you can see they're kind of sharing advice and knowledge with each other, but they're kind of separated from the rest of our service, right? They're not really sharing a lot of knowledge with our other frontline staff, including our mental health staff, but even with our AOD peers. And so if you think about what that means for a service, we have all this AOD clinical knowledge, but these members of staff are not kind of using that knowledge to advise their colleagues to help them improve their practice. And so that did look great for integration. Now, that's not the only way we can use this data to think about integration. Another thing we can look at is who's influential over practice. So one way to do that is to look at who are the advice hubs. So an advice hub is a person whose network looks like this, right? They're the people who lots of people are going to for help and advice. And if you think about what that means, if you're giving a lot of knowledge to your colleagues, you probably kind of know what you're doing, you're influential over the work, you're influential over practice. So we can count up the number of advice nominations everybody gets, and we can size people accordingly. And then what starts to stand out is kind of who are the influential people in the service. And the first thing you see is that these people that are coloured white are pretty influential. They're mostly the service managers, so that makes sense, right? They're advising their colleagues a lot about work. But if we look at our frontline staff, we see that it's mainly a couple of our mental health clinicians that were kind of really providing a lot of advice at this time. And so that mental health clinical perspective was pretty influential in the service. Now, we need to ask ourselves, why does our informal organization look like this? Okay, it's not because our staff aren't doing a good job, and it's not because they're not trying to share knowledge and help each other out. Actually, one big reason we saw this was that rotating roster structure that I told you about earlier. So you might be a member of staff and you may need help and advice from an AOD clinician, but if you are not rostered on the same duty as them or you're not working on the same day, it might be really hard to access them for help. And so the point here is that when it comes to integration, we can't just put our staff together in the same workspace and expect them to work it out, expect them to integrate. We really need to think about how the formal design of our services shape staff's ability to kind of share knowledge and integrate practice. And that separation between our mental health and our AOD staff was also evident in staff confidence in their care and support skills. So in the survey, we asked staff questions about how confident they felt providing mental health care and support, how confident they felt providing AOD care and support. So we gave them statements like, I feel skilled in building rapport and trust with consumers with AOD needs, asked them to agree or disagree with that statement. And based on that, we can create a confidence score for every member of staff. And then we can look at the distribution of confidence scores across all the staff in our service. And that's what's shown in this chart. So on the x-axis here, you've got level of confidence from not at all confident to very confident. And these mountain plots, the height of the peak shows where our staff are clustered, right, around that confidence score. And the little lines show the average score. So when you look at mental health care and support, you can see that looked really great, right, at this time. Most of our staff were really confident in mental health care. When it came to AOD care, we had this whole spread. So we had some staff who felt really confident, and then a number of staff who didn't feel very confident at all. So again, if a consumer walks into our service and they need support with substance use, they may engage with one of these members of staff who doesn't feel super confident actually providing help. And so again, that's a challenge for integration. So the service leadership would recognize some of these integration challenges, and they took a number of actions to try to restructure the service and improve integration. So a couple of things they did was restructured away from that rotating roster structure, and now we have these small multi-practitioner teams. So we've got 4 teams now, this Welcome and Connect team, which does that intake part of the workflow, and then the Communities and Pathway team, A, B, and C, and they all do the rest of the care and support work. The key points about these teams are, first of all, they're multi-practitioner. So you can see there's a mix of mental health, AOD practitioners, and people with other expertise. The other thing is they're fixed, right? People are in the same team every day now. They're not in this rotating roster. So hopefully that should create that stability to build those relationships. The other thing they did was they took one of our AOD clinicians and created a new role for them of specialist mental health and AOD clinician. And the point of this role was for this person to work across all the teams and upskill staff in AOD, improve processes, and improve integration. And then the other thing we did is that myself and this specialist clinician went through every stage of the workflow, and we consulted with our staff, what are the barriers to AOD integration? And so by that, we mean anything that makes it hard for you to provide effective support to consumers with AOD challenges. And so just some examples of the kind of barriers that staff had at the time. This is just talking about that initial engagement stage of the workflow. And the kinds of things that came up was our staff didn't always feel confident asking AOD questions in a safe and non-stigmatizing way. They didn't always feel confident spotting AOD risks. Some lacked knowledge of substances and associated risks. They weren't always confident of how to record AOD information for allocation purposes and engaging with intoxicated consumers. But the important thing was that the specialist clinician went through and they designed their work plan and the content of their role to address these barriers. So they started doing things like AOD orientation for all our staff with education on substances, harm reduction, etc. They started role modeling AOD recovery language to reduce stigma and build confidence. They sat in primary consultations alongside staff to help them build skills. But the important point here is that we're thinking about those 2 elements of service design at the same time, right? We're thinking about how we design our roles, that formal structure, alongside the setup of our workflow. And I won't labor the point, but these are just a few more of the barriers that came up in the care and support period. And again, the specialist clinician designed their work plan, their role, to address these barriers. And so we went back a few months after that work began to look at what had changed in our service. And so this is our advice network at time 2, that's February this year. And one thing that you can see straight away, this green person is our specialist clinician here, right? So they were formerly an AOD clinician. You can see they've moved from the periphery of the network here into the middle. So it looks like they're sharing a lot more knowledge with their colleagues. And actually, when we count up the number of knowledge sharing relationships, you can see that they've become kind of as important as some of our mental health clinicians there for sharing knowledge. And actually, in that short space of time, they went from a rank of 49 out of 52 in terms of the number of advice relationships they had, up to 16 out of 66. And they actually became our most important member of AOD staff for advising their colleagues. And so this is something one of our staff told us about that specialist clinician. They said, specialist clinician made us feel really assured that we were on the right path and gave us little pieces of advice, a little bit of boosting in our skills. She joined our meetings a lot, and she never hesitated to take time to talk to us. So you can see the impact of having access to that person. And the important point is this is not about having a new individual with new skills in the service. This was formerly one of our AOD clinicians, but that new role gave them the scope to kind of go out and do this background work and kind of upskill their colleagues. The other thing we can see is our AOD clinicians, whereas they're in a little group on their own before, they've now moved into their teams and they're sharing knowledge with their mental health colleagues. So again, that looks much better. And I'm really sorry about that. I should have muted those, and I will do after this presentation. So this was something our staff told us about, having an AOD clinician in our team. Thanks, Tom. With the AOD clinician being in our team, I get to know her better, so it's easy to go up to her and to ask her questions. So again, that presence really had an impact. And we also saw a change in skills confidence amongst our staff. So this is the distribution at time 1 that I just showed you, with our staff feeling not too confident. By time 2, a lot of our lower confidence staff had moved up to this mid-range. Some of our higher confidence staff were reduced. Now, one big reason for that was right after the first survey, our service started systematically taking more complex referrals, so staff found that quite challenging. But I think one thing we can say is that a service where everyone feels kind of at least moderately confident is probably better for integration than we have these low confidence staff. And that's actually changed again since then, so I'll show you in a minute some of the change. But just sort of takeaways from this work. So the first takeaway for me is that we need to think about service design holistically, as targeting kind of the 3 elements and those interdependencies between them. So in this case, we changed our structure by creating that specialist role and restructuring our teams. We targeted upskilling and process changes at those critical points in the workflow. And then we saw that change in knowledge sharing and in staff skills. But I think what we often do when we're doing service improvement is we might only focus on one of these things at a time. So we might do things like training and try to improve those informal skills staff have. But if we don't change our workflow so they have chances to kind of practice and embed these skills, then it's not going to be so effective for service improvement. The second takeaway is we can think about service design as a continuous improvement process, right? So it's not something we just do at the point of tendering or when we're setting up the service. It's this ongoing process where we identify challenges, and that should be done in terms of those 3 elements. Implement target change in that holistic way I just mentioned, and then monitor the impact. So this is crucial, right? And when we're monitoring impacts, we should be looking at staff experience as well as consumer experience. And I think in our sector, we're often better at the latter than we are the former. And we should be thinking about efficiency as well as quality, especially as our funding becomes more constrained. So also then we need to spread lessons, right? So one lesson of this work for me is thinking about how can we design roles for service integration, like that specialist clinician role. Final takeaway, lessons for integrated services. What works? One, calling integration practitioner roles like that specialist clinician. And the important part is that role was tasked with doing in-house service development, right? In-house upskilling, process changes, which work really well alongside external sources of support that we've had from the Hamilton Center, which has been really fantastic. And it's not just consumer facing, right? This person had the scope to do some of that background work in integration. Small multi-practitioner teams work to help people get to know one another and share knowledge. Embedded research was very effective because by working closely with our clinicians, I was able to translate some of the research findings into changes, and then we could go back and monitor what had happened, and that informs leadership decision-making. What's challenging is recruiting to integration practitioner roles. So after we did that second wave of the survey, our specialist clinician left and moved into state. And there was a while where we struggled to find someone with the right mix of skills to do that role. Now we've got a fantastic new specialist clinician, Corinne, who's in the river, and she's picked up that work. But I think we can think as a sector about how we create pathways for those kind of integration practitioner roles, and then thinking differently about roles and resourcing. So again, this role, specialist clinician role, was not just consumer facing, right? They had the resources to do that background work. And finally, just coming back to this idea of monitoring service improvement. So I went back last month and resurveyed our staff, and this is the distribution of our staff AOD skills confidence last month. And you can see pretty much everyone has moved above this moderate confidence level, and we now have a kind of significant average improvement in our AOD confidence. And so I think my takeaway is because of the flexibility of the locals model and the locals funding to enable us to kind of experiment with different ways of doing things, it's really enabled us to play around and do these continuous improvement processes. So yeah, thank you.
What a great way to kick off today. It strikes me as something funny that 20 years ago I stumbled through the inpatient door during a drug detox, and now I'm here talking in front of us today. And it speaks a lot to the way that our movement has changed and the way that we've got great representation. So I hope that this is something that continues. However, when I did my cert for an AOD in 2007, we were still talking about many of the same issues. We were still talking about how AOD was misunderstood, how it was marginalised, how it was stigmatised, how it was often ruled by clinicians, even though AOD has such a long history of unpaid peer support. So really mental health kind of owes a bit of a favour to AOD for the peer support stuff that we did originally create and still have going. I noticed here there were several things I was very excited about. One was the idea of having new roles that combined AOD and mental health, because since 2007, even when I started practicing AOD, it was so siloed and the knowledge was seen was so separate. But my point of view as a lived experience person was actually that AOD and mental health had so many things in common, and that the responses that I needed to both of those were very, very similar. I never quite got all of the AOD support that I would have liked, and I would have loved to have seen this kind of support available to me. And I think that there's a really good story here about working together. It's great to see so many of us from the industry all here talking together. And I think that there's a big thing here around building confidence around AOD and mental health, and AOD and mental health together, that I think is still unspoken. So it's great to see this work, and it's great to see design and organisational theory happening and being incorporated into mental health services and AOD, because I think that's something that we're also really lacking. Thank you so much.